Welcome to Home Health 360, a podcast presented by AlayaCare. I'm your host, Jeff Howell, and this is the show about learning from the best in home health care from around the globe. Hi, everyone, and welcome to another electrifying edition of the Home Health 360 podcast. We have a couple of really interesting guests on today's show. Do you remember when COVID was just breaking out in the US? It was the height of everyone's fear, as we really didn't know what we were dealing with at the time. I just remember the first outbreak was in Washington, and I thought it was near Seattle. Well, my guests today are from Evergreen Health out of Kirkland, Washington, and they had to deal with the very first COVID death in the United States. This is a fight that none of us asked for, but imagine having to be one of the very first ones responding to the pandemic on the front lines. Today, I'm joined by Molly McDonald, the Program Manager for Quality and Regulatory Compliance. Molly, welcome to the show.
Thank you. Thanks for having me.
And I'm also joined by Brent Corti, the Chief Home Care Officer. And I think that is the first and only time I've come across that exact title in the industry. So that's pretty cool. Thanks for stopping by, Brent.
Sure. Hopefully the title's coming on strong, but you're right. I haven't heard a lot of other folks with the same title yet.
Well, let's start with this. I recently learned that your health system has a 5-star rating, and I've come to learn that's pretty rare for CMS as well. So can you guys give me some insights into what some of the keys are to success to getting such a high rating?
Yeah, Molly, maybe I can start by clarifying. We are super focused on home care, on home health, and on hospice. A bit about Evergreen Health. We're a larger format home health and hospice provider. So our hospice census is right over 500 and home health is right around 1,500 patients. And we have an outpatient hospice as well. We're associated with a hospital that has very high quality as well. That hospital has a 5-star rating. Our home health has a 4.5-star rating, which is something, in and of itself, frankly, we are quite proud of. And although we certainly are always striving for 5 stars, given our volume and the difficulty, the risk associated with the patients, the level of acuity of the patients in particular that we provide care for, we have been super happy and very proud of our clinicians in particular who've helped us reach that 4.5-star rating through the multiple vehicles of the quality deluge of home health, value-based purchasing, which is obviously going to become something far bigger in less than a year now nationally. There's quite a bit. So I don't know, Jeff, would you prefer we focus on how the system has improved their rating to 5 stars or how we as a home care provider have built our quality machine, so to say?
Yeah, that's what I'd like to dial in on for the agencies that may be listening out there, trying to figure out, what does better patient outcomes mean to you and to them?
Yeah, sure. I'd love to talk about that. And I think too, just even listening to that, it really speaks to how complicated all these ratings are. It seems like it would be so straightforward, but there's, multiple different ratings out there for hospital, for SNF, for home health, and, soon to be hospice and things like that. And I think that just speaks to the complexity of it and what makes it so difficult. And in home health, we've come a long way. We aren't exactly at 5 stars yet, but we're headed there, hopefully. And we've come a long way to get to 4.5. And I think really with a lot of the programs, either from CMS or from the state, is making sure that this is something that we don't just let happen to us. All of these things, this is something that we're going to manage, that we're going to get in front of. And that's really what we've been doing so far and what we continue to plan to do to continue success in this, if that makes sense. And so we just, proactive is what you want to be, and not month to month react to things and just say, they'll fall as they may. It's like, no, I'm not a big fan of surprises. So I want to know where we're headed and what we're expecting to see. Mm-hmm. And so that's kind of the approach we've taken, is to manage it. And we do that by educating a ton and making it front of everything. Every meeting we're having with clinicians, with other staff, and really key to remember that we are more. There's so many different departments, and each department has their own impact on all these metrics, whether it's value-based purchasing or stars. And so we see that as a bigger picture here. And so each department is getting their own little spin on, hey, this is what's going to happen. Here's the new program coming out. And here's, more importantly, your impact on this program. Mm-hmm. And so education is not just really the workings of it for us. It's the ins and outs of how the program might work. Obviously, there needs to be people that know that at the agency. But when we think education here, we think, impact. And so here it is, and here's the impact your work on a day-to-day is going to have. That's really worked for us.
Bit to add on to that. First off, I want to significantly acknowledge that Molly has been the backbone and the brains behind our design of our quality improvement. And we have had a significant design associated with improving our quality really since value-based purchasing started in the 9 pilot states, obviously Washington being one of them. Molly was talking about really what I view as intentionality. When we talk about improving quality, it can very often, and for good reason, be relegated within many providers as we have someone that does quality, or we have someone that looks at Oasis, or we have someone that does so-and-so. But we instead have made quality front and center culturally to our organization. And that's easy for me to say in my role, easy for Molly to say in hers. But I would hope as I look out my window to my left, as I see clinicians coming and going, that each one of them would say that they each have had their journey of understanding quality and caring for quality, and likewise bringing quality full circle to help improve our ability to keep our people. So they care. They have pride in the fact that we are ideally the top quality provider in our service area. That's different. There's a different approach to that, and we have very materially worked on culture building, quality building, quality building, so that within our culture down to the clinician level, people understand that in order to be the top of our game, the best home care provider, we hope, we want to be. I'm not going to say that we are or we are not, but in our current service area, that involves expertise down to the level of the clinician, up to the level of the clinicians, probably an even more appropriate way to say it. So it is endemic to our culture. We do set very high expectations, materially through dashboards and materially through through leadership. And we set high expectations from day one when we hire new people, when we orient them. And I would say the keys to success and quality are living a quality mindset, and that's a catchphrase, but there is a way to do it, and we do that. We're proud of the way we've designed our quality machine, for lack of a better way to put it.
I love the way you phrase the sort of the culture and the quality, the culture, the quality. You weren't going to get away here without talking about attracting and retaining. Give us some idea of what you guys are up to with respect to when you start out at the very beginning, finding the right people and then onboarding them properly, and then the ongoing training and culture development. How do you guys excel with respect to attracting and retaining caregivers?
Anyone in a leadership position has long heard that we need to work harder to keep our people, and that's true. But it's sort of become part of the business ethic of we need to do our best to keep our people, but we have so-and-so priority, so-and-so priority, so-and-so priority. But what's really happened there is we have been, from a market dynamics perspective, micro in our current territory, micro to home care, micro to home health, micro to hospice, you name it, or macro within the United States, then Canada. Imagine worldwide, where it really does matter now, where people are evaluating their lives. They're evaluating, do I want to be a physical therapist? Do I want to be a nurse? Do I want to be a physician? Do I want to be a chief home care officer? Is this the way that I want to spend my time? So we have taken a laser focused approach to trying to ensure that we have not only very audacious goals related to how we keep our people, but that we take action. Again, super easy to say, well, we want to be a great provider, but putting the action behind it involves a lot of work as leaders and a lot of building of again, another catchphrase, but building of culture. What does that actually mean? At Evergreen Health, and I would say that, and personally with the personalities that Molly, myself, that the rest of our excellent leadership team have, are that we stop and listen and care deeply about what the clinicians are seeing in the field. If we don't know what is happening when we walk in a home, if we don't know more importantly what the person who lives in the home is feeling when we walk in the home, what is our brand, what is the value that we're actually providing to them, what's the value we provide to hospitals, to our primary partners, to health systems. We work really hard to know that, and to do that, you have to be vulnerable. The V word, you have to be vulnerable to this idea that you're going to hear things you don't want to hear, and you got to make changes. So we have a material mechanism at Evergreen Health to make sure that anyone on the front line or in our excellent support staff as well have the ability to raise their hand and say, this does not, look, taste, smell, feel right, sound right. And we have a way to sort of bring that forward and make sure that we can make adjustments. And sometimes it's very sort of specific to the person, and it's not a organizational wide issue, but very often it's something that we are blind to. It's easy to be blind to things as leaders. So we materially expose ourselves to this idea that we need to constantly improve and constantly work to keep our people. We track our tenure, so essentially length of employment, very, very, very carefully. So I'll share we're right under 8 years. And that includes,
wow.
Yeah, so we're really proud of that one. That includes all the new people that we bring on. So if we have, this week, we're orienting 6 new hospice and home health clinicians. In theory, they bring that number down as new employees, and we're still able to sort of keep that top end.
Yeah, for sure.
We also track turnover, and we track retention per department and on a team by team basis.
And I think too, like when you are talking about really asking our employees, like what quality means to them. When we talk about quality culture, it's our role to kind of make sure those are connecting and making sure that, the rules and regulations and the programs that we have to do, we're entwining those with what our clinicians and what our staff feel is quality and better quality care. So we're constantly saying, what does this mean to you, and how we can figure out to get those together and move forward from the get-go. Like Brent was saying, this is from day one, we're talking about this. This is in the interview process. This is even like pre-day one, we're talking about this with folks that may or may not come work for us. So it's that much part of everybody's workings that it starts immediately. And I think the other piece too that we really pride ourselves on and is really impactful is our transparency around everything. We try to make sure that that's happening at every single level. And if it's not, like Brett said, we want to hear it. If you feel like we're not being transparent, and we can really kind of think about how that can go better in the future. And that's just a constant kind of thought process with our leadership team about everything, whether it's STAR, value-based purchasing, retention, COVID, you name it. That's really at the top of our minds.
Well, I think an average tenure of 8 years is probably the biggest number I have heard. So that's an amazing number to track. I know we have some anonymized data that actually shows that the older the caregiver, the longer they'll stay at the agency. So people in their 20s, 30s, 40s, 50s, 60s, it's a straight line up. And so I thought that was interesting because I thought it might have an arc to it and sort of come down. But yeah, according to the data that we have, if you hire a caregiver in their 60s, they probably will stay at your agency longer than someone in their 50s and, down the road, like at every 10-year age cohort. And I love this idea that you are, your caregivers are your foundation. And if they're turning over, then it won't lead to a 4.5 star rating because you're not filling shifts. You're not able to deliver the care. Brent, you said, figuring out what is happening in the home. I'm curious to talk about what is going to happen. And I'd love to get your take on next generation technology to predict what's going to happen. And from the folks that I've spoken with in health systems, the industry still needs to get to a point where, we're reporting on many more things and we're using machine learning and we're actually trying to figure things out before they actually happen. I'm curious what kind of things you guys are either utilizing today or you're looking at, and both of your general thoughts on the industry in general in this regard.
This will be a two-sided coin answer, Jeff. The first side is really that I think that much of the technology that home care providers, larger format, smaller format folks, system-based folks, for-profits, nonprofits, you name it, have been seeking has been sort of finding the shiniest object. That shiny object is often, telehealth, which in and of itself is a very wide-ranging title or term. We're now learning that telehealth means a lot more than something akin to the Jetsons or something akin to biometry only or you name it. And we aren't totally there yet, frankly, on the telehealth craze. I don't know if the object was shiny enough for us, and I don't know that the object is as shiny as it is sort of seems when you get the closer you get to it. It doesn't seem as shiny, meaning this, that it seems like on the telehealth front, at least, that perhaps the industry is still deeply defining itself as it pertains to home health, and then very separately as it pertains to hospice. There are excellent use cases there. There are excellent applications, in particular for reaching folks on the hospice front, and it solves materially the economic issue that sort of comes inherent to home health.
Mm-hmm.
What are economic limiters within home health? Well, windshield time, drive time. Okay, so how many visits are you able to do a day? So if we were able to be beaming clinicians into people's homes, we could do a heck of a lot more visits versus sitting idle in a car, or not technically sitting idle. If you're in downtown Seattle, you're probably sitting idle, frankly. But as you're driving around, generally not necessarily being productive. So what can you do at that time? Well, you either have to do something in that time, or you have to eliminate that time. Telehealth solves at least one half of that problem, yet it is still undefined. From a from a predictive analysis perspective, super excited about the technology that's coming. I can't speak as much to machine learning, but I do know that when we look towards our future, Evergreen Health's future, we want to be able to provide better care to folks that are needing it, and use predictive analysis to help us ensure that the care we're providing, that we're most prepared for it. And this involves not just the day of the visit, the day of a patient's potential imminent death if you're on the hospice front, but it involves how we staff. It involves what do population dynamics look like in our area, in our service area, and other service areas as we start providing greater value to our patients and our families. So we're super excited about predictive analysis. Am I lukewarm on telehealth? No, super excited about it, but I just am looking. I'm looking for a little more definition, a little more shine before we make that significant investment. I don't know that it's quote sexy enough for us to sign into yet another telehealth platform and then ask ourselves, what was our intention behind doing this? First, what problem are we trying to solve, and how does technology solve it? So that's more of our approach.
I think so too. From the telehealth, when I talk to some clinicians about it, some of the hesitancy is, home health is obviously the environment is the home. And so when it comes from telehealth, so many things, the next step to the question, whether you're assessing something, is, well, let's go take a look at that. Let's go see how you're doing in your environment. And the telehealth piece feels very limiting in that. It's like probably not the safest to say, hey, can you pick up your computer or your tablet and go walk around with it to your house? And that feels very, very odd. And so I think finding where the balance of using telehealth to meet the needs of patients and caregivers is just, it's been a little bit of a slower go as opposed to like a static provider appointment or something like that. And I know rehab staff too is just not as used to using telehealth. It's not something historically we've done a ton of, especially in home health. And so that's who I would talk to a lot about it, where, one thing with like telemonitoring, and that's been around forever and things like that, but the actual hands-on work, I think, is a little bit tougher to wrap our heads around when it comes to telehealth and home health. And I think too, with predictive analytics, I mean, when we talk about data and outcomes, it's one thing. And then the other part is, as we grow as a provider, as we grow in where we live in Seattle, using it to tailor care specific to that region or that patient even, I think that's what's super exciting, that we can really utilize moving forward a lot more than we do.
I don't know if it's just me, but I also feel like telehealth needs to mature as an industry. There seems to be no clear winner. And, it's a whole bunch of small companies that are, standalone pieces. And I just feel like in any industry, you need to have someone who emerges with the right funding, the right, product, and the market can get behind that. And there's I just don't feel like there's a clear winner right now.
Yeah, Jeff, I agree fully. And again, economically, we have a ton of money going into this. We know that there's a lot of investment, whether it's private equity investment or just a number of companies that have IPO'd in the last 24 months. So it isn't lack of attention or money, perhaps. It may just be sort of asking ourselves, what is the problem we're trying to solve? And very interestingly, it sort of switched to another example that I think Molly had mentioned. During the pandemic, we were forced very early to figure out how to ensure that our folks were communicating when they are no longer able to see each other. And the grand irony there is this was a national problem for folks that generally weren't working from home, that show up in the office environment and there's the water cooler and the fridge and the lunchroom and all that. But we already didn't have those things. We have the highway I-5 for us is our hallway. So we were used to a remote workforce, and some of these tools that have come up, some of them were already there, some of them have propped up, but that allow us to look into a camera, to talk, to be as close to real collaboration as we were when we were in the room. But what does that do for home care? It saves a heck of a lot of time for folks having to drive into our headquarters, and that's one out of 12,000-ish agencies nationally that is probably experiencing a significant increase in productivity, and likely back to the employee satisfaction piece, that people are able to collaborate, and that from a tech perspective and next gen technology, I'd be super excited to see how people can collaborate to where it feels even more like we're in a room, that we're actually in the same area, and maybe that'll be the future from a home care perspective, that it can feel more tangible. In particular, our average age, Molly, 82-ish?
Yeah, usually mid to low 80. Mm-hmm.
Yeah, the concept of adopting technology too. We're actually getting in this point where the entire boomer generation will have been using their thumbs on their mobile devices for a long period of time, and we're getting into that. So that's going to change the vernacular as well.
Well, and a silver lining of the pandemic is everyone's grandma knows how to use Zoom as well, right? So when we speak about telehealth, technology adoption is one of the big challenges. And, certainly we've all been forced to adapt.
I think too, just to another thing that just made me think of this is really listening to all these conversations, and everything kind of comes around back to, improving patient outcomes and the whole patient experience. I think, we're seeing that, and we're having the investment of our clinicians and this technology. Our clinicians are feeling more supported. Like their leader can hop in on a patient conversation and be in these, IDTs or whatever your agency calls it. The leader can pop in on these all over the place, immediate. And so they're feeling more supported. And so it just really, it goes everywhere when we can do that from the get-go. And some of these technologies have really let us do that. So even though we've been, a bit remote this whole time, using these is just really upped everything in that aspect. So that was kind of an unintended, obviously, of the pandemic. It kind of forced us into that I don't know when we would have gotten to that point without it.
For the layman out there, you hear this narrative that the knee-jerk reaction is, we have a pandemic. We need to get our seniors out of buildings and back into homes. I'm curious if, I draw the analogy to September 11th. And at the time I was in commercial real estate, and there were people that thought no one's ever going to rent space in office towers again we saw this, it happened. So it's so graphic. And then a short time later, just prior to the pandemic, the vacancy rates in Manhattan, they've never were at a more favorable vacancy rate. So I'm curious, your thoughts, like what you're seeing in growth of service lines and, assisted living, hospice. Most people carry this narrative that the future of care is health in the home. And of course we see the value in that, but I'm curious from a facility standpoint, if you guys also see us actually just kind of getting back to normal, and people will forget about the pandemic, and at some stage life just goes back to how it was, because, there are different aspects of the healthcare continuum that were necessary. And once we get back to normal in the hopefully not so distant future, things will go back to normal. What are your thoughts on that?
Yeah, just to speak to the whole, are we going to go back to normal? I think we We saw a little bit of that just as we've gone through the pandemic in the 2 years that we've been in this. Things kind of, aggressive at first, and then they kind of pull back, and then as things surge, we've seen it go back and forth. So I do think there's going to be a component to that at one point. And I think, the narrative of the future is in the home. I think it's more than a narrative. Obviously, I'm in this in this work for that reason. So it's a little bit more than hope. That's not the best strategy. I do think we're moving that direction. I think home health and hospice has done a great deal of work to prove that narrative is true, and that our folks are getting better. We are at the table to support the facilities and to keep people out of that from a health perspective, a satisfaction perspective, a financial perspective, that we have our place. And I think we're just getting better and better at showing that.
Yeah. I just wrote a few notes down. So I love this question. We all want to say that home care is the future because we work in home care. It's great. Okay. But behind that, again, I go back to to looking at the economics of what's happening. We know, it's very convenient to say that we have the quote silver tsunami, and we have the baby boomers that are going to need care, which is certainly significantly in excess of present supply. That seems very clear. I think there's something else at play, though. One of them is this, and we're seeing it today. This is the timing of this question is excellent. We're seeing it today as the Omicron variant of COVID is overwhelming our nation's healthcare infrastructure. At our own hospital, we are doing within our system I would say, very good job of managing an onslaught of patients, and the ED is as busy as we've ever heard that it's been, opening new floors where our hospice care centers is very busy with trying to take overflow patients, you name it. What that means is that during this likely busiest phase of the pandemic, now not the grimmest phase perhaps, you think about New York in April 2020, you think about so many cities in New Orleans, you name it, frankly, Seattle on the 29th of February 2020 on Leap Day. But today something different's happening where we have a numbers game where we have folks that are much more people are getting sick, but the level of their sickness is significantly worse, which means hospitals are getting overwhelmed, which speaks to this one fact. Are there enough hospitals in the United States? Now, it's easy to say today in Washington State there are not. We need more help. But in general, looking at the numbers, minus the pandemic, there's enough ability to take care of trauma and acute care, et cetera, et cetera. Will that change in the future? Well, it could, but there's the bigger play is that consumer intentions within the economy have changed. People have realized that they don't have to, number one, be at a hospital, but number two, they don't want to be at a hospital. It could be that the food, that I don't like Jell-O. It could be that the TV's too small and too far away, and I don't understand that remote that's on the court. It could be the fact that they don't want someone coughing next to them. It could be also, more importantly, that they realize that technology and healthcare and this industry that was formerly in the shadows called home health and hospice, home care in general, is now front and center because they're seeing people come into their homes. They're seeing folks go into their neighbors' homes, and they're thinking, well, that's pretty smart. I now don't have to expose myself to illness or to, frankly, what's generally not the most enjoyable time to being in a hospital. And now I can stay at home. And there's just so much exciting work relative to that. So I think the tides are changing, Jeff. I think it's permanent. Are we going to see hospitals continue to be built? So long as you have folks that are trying to compete for a better hospital, for a more beautiful hospital, for a taller building, yes, you're going to see that. But I think in general, over time, we're probably going to see so much of the care go back into the community, which is logical.
Well, and I think we're seeing that too, not just in home health, but all these, we're hearing about new programs happening all the time, whether it's, outpatient therapy that's now going to the home, or, in some of the tech companies, they're having their almost internal health system, and it's very technology based, of course, but, bringing it to the consumer, and we're like, hey, that's we've been doing this. That's our gig, like, yeah.
That leads into my next question, because I was going to ask about predictions for hospital at home. And there's so much confusion around this topic. And it's like what you say, Molly. It's like, you guys have been doing this. My question really is, and I say this as a layman, is, so my latest understanding is that hospitals are trying to wrestle control to administer the care at home instead of contracting out to home health agencies. So I'm curious on your take on that. But I'm also just wondering, at what level. My view is hospital at home actually involves more medical equipment that you don't traditionally find in home health, that somewhat chronically ill patients will have some kind of devices that they require that will be residing in their home to sort of make this almost like a makeshift hospital for them. Am I somewhat accurate on that, or what am I missing on it?
Yeah, I admittedly, I'm not by any means an expert in hospital at home, but when I hear people talk about it a lot, there's components of that already in home health when we talk about devices and, in particular what Brent's been talking about with the Omicron. I mean, we're seeing a lot sicker people at home, and it's just kind of been ramping up as the pandemic has gone. Even previous to the pandemic, honestly, we saw that, but it's just more, I guess, acute. Since the pandemic's been starting. So we have been seeing some of that already, and there's room for that. I think what's really cool when I read about hospital at home, just kind of the opportunity and the potential we have to take the best of both worlds and make something really great and say, hey, we have these experts in home health and we have the experts in the hospital. Let's put this together and make it efficient. And so it's a really, really great opportunity. And I mean, we have some folks that are, and I think when we were chatting about this before, we said something about like there's lots of days that we feel like in the current home health environment, we're just a heartbeat away from being, a hospital at home, minus a lot of the facility, obviously, and the equipment and things that we talk about. But the patients are there, the need is there for sure, and we're kind of organically rising up to meet it when we can and where we can. So it's already built in a little bit into the system.
The design is quite simple. Remove capital costs, find the right patient type, provide care. So capital costs, if we all, well, actually some people may or may not understand that building a hospital is excessively expensive because of code, because of frankly markup from contractors, and it's really something else. So removing that cost is excellent. So this is an emerging market. I think it's designed. The design behind it is super intuitive, but I think we're going to run into some operational cliffs. If a hospital, my experience has said, and Evergreen is actually, I'm not trying to play it safe here at all. Evergreen Health has done a wonderful job of embracing this idea that 15% of our system is home care at this point. Okay. The system in and of itself have done a beautiful job saying, we get that what you're doing is not the same as running a med-surg floor, doing surgery, or delivering babies, or doing scans, you name it. I worry that notion that, respectful to everyone who's administrators in hospitals right now, that the notion of, well, we can do it better because we know how to run healthcare because we know how to run a hospital, that will not work in hospital at home. There's going to have to be a strong home care element, but more importantly, someone who understands how to run a business which is remote and how to run a business which involves significant logistics that don't just come to one place.
Yeah.
We're in and out of 2,000 homes today.
Yeah. By logistics, you mean chaos, right?
Yeah.
Well, right. And I think too, like is really not making it a competition and not pitting it, but really let's, keeping your eye on kind of the end game and make, like we talked about, taking the best of both, but working at the same time. I mean, yeah. and together, not to sound cliche, but we have to do that for it to succeed. We can't make it better for one of the systems and worse for the other. It's just like it's not going to be sustainable.
Yeah, that makes sense. Brent, circling back on when the pandemic hit. So my understanding is that you gave a presentation at the Home Care 100 conference, and this was, I presume, the response plan that you folks put together as a result of, being sort of the first to have to deal with the outbreak?
Yeah, that was something else. So going back to what would be late January, early February, I think it was specifically early February 2020. We had the normal Home Care 100 conference, so that's coming up in Phoenix in a couple weeks. But this is now 2 years ago. We had the normal conference, and then we got back, and it was amazing. We literally had just gotten back. I'd been away from my family at the conference. I was putting my daughter to bed, and I got a call from my boss, and she sits in our senior leadership team at the system, and said, "Are you sitting down?" And I wasn't. I was, like I said, put my 8-year-old daughter 2 years ago to bed, and she said, "We've had a death at the hospital." I'm like, "Oh, not shocker, right? It's what we do. We have a lot of deaths at our hospital, and our home health, or our hospice rather." And it was a COVID positive patient, and I'll never forget it. I'll just never forget that moment. So when we go into work the next day, this is now a Saturday, and we get through the next 2 days. Molly and I were in there. A number of other leaders from Evergreen Health Home Care were at our hospital, just trying to work through incident command. It's amazing to see a well-run incident command, and Evergreen Health just did a beautiful job. It could have been an earthquake, it could have been a terrorist event, you name it, but they just were the utmost professionals. The CDC was there, and news vans were there, and we were literally advising the CDC. We for a moment thought the CDC would be telling us what to do. Instead, it was the opposite. And then Monday rolls around. So this is through the week, and Monday rolls around. I think it was very early in the week, and we did a call for the Home Care 100 intelligence group. And interesting enough, I'd be curious to go back and listen to it, because we were absolutely raw, sleepless, 16 to 20-hour days for weeks on end, and this was the beginning of that. So sort of surfing off of adrenaline, and just trying to solve problems, trying to figure out how we're going to keep our people safe. We realized early we had 3 goals, Jeff. The goals were to keep our people safe, to keep providing care in the community. Now remember, at the time, the idea of, are you actually going to send your staff out into people's homes where you could spread the disease, or where our staff could get the disease? This was a very scary concept in the moment. So those were 2 of the 3. And the last one was that we wanted to stay in business. We recognized very early that we're going to have to do things provide care very surgically, for lack of a better way to put it, to make sure that we are going to protect every part of our operation, our employees first, our community, and our patients second, and then make sure that they're employed. That was the finest of tight ropes, or the thinnest line, I suppose, we've ever had to walk, and we did it. Was it perfect? No, but it was really maybe the most unforgettable part of my career personally that I may not remember. I remember the feeling of it, but it's hard to remember day after day after day. Molly really led our home care incident command. So we would go to the hospital and have their incident command, then we'd come here, and Molly was one of our top leaders of our incident command, which, and I'll hand it off to Molly in just a second, which says, I think it also speaks to our culture, it didn't have to be me. And frankly, it was Molly, because she was right for the position to make sure that everyone in their seat was doing their job and advancing the cause, that we were remaining objective, and it allowed me to lead our organization the way I need to lead our organization, and her to do the same thing.
Thanks so much. That was very nice things to say. I think the biggest part in the beginning was so unknown. And we had our 3 goals, and, asking people, doing things that may spread it or not spread it or keep you protected. It just, we didn't know. And so we were asking for so much trust and faith in each other, in our system, at Evergreen Health, that's system, in our clinicians. And that, again, speaking to what Brent was talking about, in our culture, it was just ingrained from the beginning. So it felt very like, this is what we're doing. And there was no real pushback. There was no real questions. Questions about what we were doing, I guess. We just went for it. And it worked out. And so, again, Brent said we did some things right, we did some things wrong, but we kept moving forward, and that's, I think, really what continues to make us kind of what we're doing today work, even though we're in a very different place than we were 2 years ago. But sometimes it feels like it.
Well, it was, it's incredible leadership and courage that, this is the equivalent, the healthcare equivalent of being, a surprise attack by the enemy.
Yeah, and Jeff, to make it perhaps be a bit more melodramatic about it, we have to bear in mind that February 29th was something like 60 days, 59 days from the start of PDGM, and we were about to start getting our data. So we were actually really excited going into the next, before the pandemic came. We were like, well, we built up PDGM, we built up the new payment model for home health and how we're going to change our operation to make this work. And then COVID happened. And what was 2 years of work really was like, well, I guess we're not going to know where we stand. So that made it all the more interesting to try to survive under those conditions.
Yeah. Molly, what's a trend in home health that you think is pretty powerful, but nobody's talking about?
Oof. Nobody's talking about it. I don't know about that one, but I think there's a trend, the interdisciplinary, that's been a word that's been around forever, but really sitting and thinking about it. And like Brent mentioned, our PDGM model, it's kind of, leaning more towards that is the true interdisciplinary, meaning, we're not getting together and the PT is saying, here's what I'm doing. The nurse is saying, here's what I'm doing. And the OT is saying, here's what I'm going to do. It's really kind of turning it around and saying, what are we doing for this patient together? And not saying, hey, this is what the patient needs this week. Where can we make that happen? As opposed to, it's really like, I think we're getting there, but it's still pretty siloed within ourselves. And that, I think, we just don't talk about what true interdisciplinary means and how to meet the patient's needs. The other piece that I'm thinking about that is really true, that is home health's ability to support their community. And that's something too, I think, with the pandemic has brought that out, and really making that, when we make decisions and we make our strategy, is really how we're going to do that. And our community is getting bigger and bigger as we grow, and how we have to change with that, and keeping that at the forefront of everything. And making that in the front, instead of just kind of seeing how things happen and seeing how things, when we make these changes and saying, oh, well, we'll see how it plays out in the community and things like that. It's like, that needs to be kind of in the front of our decision making before, other than, I know Brent talks about retention. He'll probably jump in on that, which is excellent as well. But speaking from a clinical perspective, I think that's something that we're almost getting there. We're getting there and getting there, but we just truly don't. We define interdisciplinary in different ways.
Well said. I'll make this one short. In order to succeed as a home health and hospice business, we need to go back to the people. And going to the people, going to our communities, going back to our staff internally is going to mean better care and success in business. And I don't think that's been talked about enough. And this speaks to the for-profit or the not-for-profit.
Well, folks, we're almost bumping up against our time here, so I'll get you out on this last question. Molly, I'll start with you, and then Brent, you can bring us home. Give us a reason to be optimistic about future in the care of the home.
I think in general, I'm super optimistic because the industry of home health and hospice and home care and our clinicians, they're just the most versatile. It's just the most versatile industry, the most versatile clinicians historically. And I know in the future, we just continue to rise up to meet the needs. And I'm super optimistic about that.
So, we know that the world became homebound in early 2020, or I will say should have certainly become homebound in early 2020. When that happened, what we were already doing was sort of thrust forward and highlighted, and home care is absolutely on the map. So why be optimistic about the future of home care and just care in the home in general? Everything we've talked about, people realize that they can achieve health, not receive health care, but they can achieve health by staying home. Home care is the bridge between public health or health and applied health care. We are the ones that are out in the community We're the ones helping patients die with less pain, helping families get through the death of family members, helping people live as independently as possible. In the boomers, the baby boomer generation that are coming are fiercely independent, and they want to skydive, right? And this is not a stereotype. It's very true. They're very independent. They want to live, and home care allows that, and it does so in a place where they're certainly comfortable. So I'm super, super optimistic about our future.
Yeah. And that generation is used to ordering everything they want on their phone. And why should home health be any different than that? Well, Molly, you said rise up, and I certainly am inspired by the work that you folks are doing. And certainly you folks have risen up throughout the pandemic. So I wish you continued success. And I'm going to be following you guys pretty closely, and I'm pretty inspired by the work that you've done. So thanks again for coming by today.
Thanks for the opportunity.
Thank you.
Home Health 360 is presented by AlayaCare. First off, I want to thank our amazing guests and listeners. To get more episodes, you can go to alayacare.com/Home Health 360. That's spelled Home Health 360, or search Home Health 360 on any of your favorite podcasting platforms. The easiest way to stay up to date on our new shows is to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. We also have a newsletter you can sign up for on alayacare.com/Home Health 360 to get alerts for new shows and more valuable content from AlayaCare right into your inbox. Thanks for listening, and we'll see you next time.